We found the average diagnostic delay exceeded 10 years, which is quite long, even for a rare disease in today's day and age. And we also found that the burden of the angioedema attacks in these patients is quite high. So these patients suffer for a long time before a diagnostic label is given.
Hello and welcome to this next episode of All Things Angioedema. My name is Thomas and I'm your host of this podcast. And as you see, we have a face-to-face interview now, and I also have a new guest today, and it's Adil Adatia. He is an assistant professor for clinical immunology and allergy in the Department of Medicine at the University of Alberta. And we have an interesting topic today we like to discuss. It's HAE with normal C1 inhibitor. So let's start with a warm welcome to Adil. Hi, Adil. How's it going?
I'm very well, thank you. And how are you today?
I'm also good. So I just had a look on how it's looking like in Canada, in the region where are you practicing. Can you tell us maybe something about the region where you live, where you practice? Is it worth to visit this region?
Absolutely. First of all, thank you for inviting me to the podcast. It's a pleasure to be here. And yes, absolutely, I would encourage our viewers and listeners to visit Canada. It's a beautiful country with lots to see. It's a country that's growing quite rapidly. We're up to over 40 million population now, and definitely we'd be happy to have visitors.
Great. Adil, I have just seen in the PubMed that you're really an active researcher in the field of HAE, and you had a lot of publications recently, not only on HAE, but also other topics. And today, as I said, we like to discuss about HAE normal. And maybe at the beginning, what actually do you personally understand by the term HAE normal C1 inhibitor?
Yeah, that's a great question, and the data we collected in this paper that we'll be discussing highlighted that people seem to understand this concept differently. Hereditary angioedema in the past was related only to type 1 and type 2 hereditary angioedema, which was hereditary angioedema with reduced C1 inhibitor function. But we now understand that there is a group of patients who have similar episodic swelling, but they have normal C1 inhibitor function. And a small subgroup of those have an identifiable genetic mutation that seems to lead to this problem. But the majority do not have an identifiable mutation, either because it is acquired in some way or because the genetic etiology has not yet been discovered. And so currently we label patients with hereditary angioedema with normal C1 inhibitor function if, of course, the C1 inhibitor function has been measured and is normal on multiple occasions. They have episodic swelling compatible with the diagnosis, and they either have a family history or they have an identifiable genetic disease. And in the case where they have a genetic mutation, we usually then rename the condition in accordance. So then we would say hereditary angioedema due to factor 12, for instance.
All right. And what does in the end then mean HAE unknown or AE unknown? What is meant by this term?
So the AE unknown is our grab-all term for the patients we don't yet put into a more clearly delineated category. And so these are the patients who seem to have a non-histaminergic form of angioedema, but there's no identifiable genetic mutation and there's no family history. And this heterogeneous group, as you know, probably is multiple groups combined. Some will probably be reclassified as having a genetic form when more genes that are relevant are discovered. And we'll have to see how the field evolves in that way.
Definitely, definitely. So you published, as you said, a paper, and that's why also I invited you. Published in 2024 a paper on this topic, HAE normal C1 inhibitor and angioedema with unknown origin. And these were the findings you had from Canada. And when you read this paper, it really looks like a very challenging condition, was expected, and I think you found this out, that these patients really face a long diagnostic delay.
Yes. We found the average diagnostic delay exceeded 10 years, which is quite long, even for a rare disease in today's day and age. And we also found that the burden of the angioedema attacks in these patients is quite high. So these patients suffer for a long time before a diagnostic label is given.
Interesting. And when you compare this disease, HAE normal, to HAE type 1, 2, where we know age of onset, usually in HAE type 1 and 2 is reported to be at the year of 12, or at latest by the end of the 20th year. How is it reported in these patients?
In these patients, we found some interesting differences between the HA normal C1 patients and the AE unknown patients. There was, in terms of phenotype, there was a difference in terms of predominant trigger. So we found estrogen was a more common trigger, as well as stress for the HAE normal C1 patients as opposed to the AE unknown patients. And that, I think, points to the fact that potentially these are different diseases, and at least some of these AE unknown patients are different entirely. And the other thing that was interesting was that even so, they were treated largely the same way with C1 inhibitor that is plasma derived, which is readily available for our patients in Canada as opposed to other LTPs used for hereditary angioedema, as well as tranexamic acid. But we had more patients with the hereditary form requiring more than one long-term prophylaxis treatment concurrently, suggesting a more active or severe form of the disease.
And you said you talk about these patients in Canada. So where was this data you talked about derived from, and all this study? Have there been patients you have seen in your clinic, or have also other clinics been involved?
So this was a pan-Canadian study. There were six angioedema centers involved, centers that were experienced in diagnosing and managing complex angioedema patients. And the study was retrospective in nature. The patient data was collected from 2012 to 2022. And in total, they collected 60 patients. And some of them came from my clinic, but many also came from clinics across the country.
So only 60 patients, so really rare condition, actually, one should say. And what were the criteria in these patients the diagnosis was based on in case of HAE normal C1 and in case of HAE or AE unknown?
So they had to have recurrent angioedema documented by a healthcare provider, normal C4, normal C1 inhibitor function and antigen level, and a lack of response to corticosteroids, antihistamines, given acutely or prophylactically. And additional but non-essential criteria were worsening with estrogen, if estrogen was received, and then, of course, a family history for the diagnosis of HAE with normal C1 inhibitor.
Um, from the clinical presentation of these patients, is this clinical presentations of HAE normal patients as reported by these healthcare data similar to the symptoms we know from HAE type 1 and 2, or are there differences?
They are similar, and I think that's probably because similarities are being looked for by the provider making the diagnosis. In the absence of a laboratory biomarker to clearly delineate, it becomes a little bit difficult because I think as clinicians we rely on our knowledge of the HAE type 1 and type 2 patients to help guide this diagnosis. But interesting differences, for example, can be found when you do have a reliable biomarker, which we do for a small number with the genetic diagnosis. So, for example, the factor 12s with their exquisite estrogen sensitivity, or the plasminogen patients who have predominantly tongue angioedema. I think those types of nuances get lost when we can't create a homogeneous group.
Mhm. As you mentioned, the inclusion criteria of these patients, and I think, as far as I remember, you also stated this clearly in the discussion part of your paper, that the data you showed and the results you showed in this paper should be somehow interpreted with caution in a way. Why is it?
So there are definitely limitations. For one, between 2012 and 2022, genetic testing had not been that common, and so we didn't describe genetic diagnoses in this paper. At our center, actually, very shortly after the data was collected, later in 2022, we began genotyping all of these patients. So that's one important limitation. The second is the retrospective nature of the design, and so we relied on the data that's available in the clinical charts, which, depending on the provider and the center and the length of time that patient had been in the clinic, could be a variable quality with some data present or missing. And then another limitation, which I think also is important for the conclusions, is that the providers across Canada were probably using quite different criteria to make a diagnosis of hereditary angioedema with normal C1 or angioedema unknown. And so all patients, for example, did not have extended courses of high dose antihistamine use. And the use of omalizumab prior to applying the diagnostic label was quite uncommon. And we conclude that having a guideline to help standardize the practice of these patients in terms of diagnosis and treatment would be very helpful, because clearly individuals are trying to interpret the data as best they can with varying outcomes. And probably patients would be better served with a more standardized approach.
Yeah, this clearly, I also agree, is an unmet need, and I hope this will come soon. Better guidelines to define these conditions of HAE normal C1
I'd
inhibitors.
I'd be curious to hear what it's like in Germany. If you think that there is a higher level of standardization in approach to these patients, or if it's similarly quite variable by provider.
Yeah, very interesting question. So I think the situation is pretty much the same, that these patients with these complicated types of angioedema are referred to reference centers of angioedema treatment. And it's quite common now that omalizumab is used to treat these patients, not only to help them, but also to diagnose these patients uh, by or with the diagnosis of mast cell mediated angioedema. So it would have been really interesting to see how many of these patients respond to omalizumab. But do you, in the other way around, face challenges in testing response as a diagnostic criterion for these patients? So, in other words, can you prescribe patients that have no hives, wheals, but angioedema? Can you prescribe them in Canada the omalizumab on the label of urticaria?
It's quite variable. It depends by province. In Alberta, we can use omalizumab when needed in this circumstance if we can demonstrate that there's a high level of impairment related to the symptoms. In other provinces, it's much more difficult. But work is being done to try and improve insurance coverage for omalizumab in these patients. And given the high cost of medications that we would try for a bradykinin-mediated angioedema, whether it's plasma-derived C1 inhibitor or biologicals. There's been some interest from the insurance coverage agencies to pursue this. But these things take time, and so right now I would say it's variable, but in some circumstances it can be quite difficult.
When we talk about response to treatment, you also showed results on the response to treatment, and there was some response in long-term prophylactic treatment or even on-demand treatment of these patients to treatments that are usually used in HAE C1 inhibitor deficiency, as you said, like C1 inhibitor concentrates and so on. Even in these patients with no mutation found or unknown mechanism, how do you actually explain, or any ideas how you could explain response to these treatments, or should it be also maybe one of the criteria to define this disease?
It's a very good question. I on the one hand, it can be, I think, useful to use a trial of treatment of this way to help support a diagnosis of a bradykinin-mediated angioedema. But one of the difficulties is that these diseases are often relapsing and remitting inherently, and so with a trial of treatment, you could, by coincidence, identify improvement, but they're not truly a responder. It was just the natural course of their disease to be more quiescent in the ensuing few months that you did your treatment trial. And so I think we need to have clear definitions of what treatment trials and treatment failures would look like. So the type of dose, the duration, and the change in disease activity that would have to be noted. Because otherwise, I think it's very easy to make the incorrect decision. And probably the same applies to omalizumab as well. What constitutes a good response to omalizumab, or a failed response that should prompt us to look elsewhere needs some refinement.
Mhm. So maybe one last question. One criteria also, as you mentioned, is response, for example, to corticosteroids. And from your experience, how would you define, or not maybe define, but what is your experience from patients reporting response or non-response to corticosteroids, even when they have clearly mast-cell-mediated angioedema? Yeah, is it always a response within one day, within a couple of hours, or how do you experience what patients, give feedback in a way, what response to them means when they have been in the ER due to angioedema and received corticosteroids? Would be interesting to know.
So I found that that it's asymmetric. So if a patient is in the emergency department with angioedema and they receive corticosteroids and they are convinced that they did respond, the likelihood that this is a mast cell mediated angioedema is very high. So that information is useful. If they're convinced that they did not respond, that information is not that helpful. Often they still will respond to antihistamines or even regular corticosteroids for treatment for attack prevention. And so I think it's useful to try and delineate in the history whether there was a response, but I wouldn't put too much weight on non-response in the acute setting. They still may well have a mast cell-mediated disease.
Very interesting point. I like this very much. So, Adil, we are actually already at the end of this podcast episode. It was really my pleasure to have you here as my guest and talking about the results you found out in your paper. And I think there's still much to do, as you said. We need to define this condition in a better way to help these patients earlier. As you said, they do not face this diagnostic delay anymore, and we need more awareness, obviously, for this disease. It's a rare disease, but it's a disease which somehow mimics clinical features, as you said, of HAE, C1 inhibitor deficiency, and even maybe also mast cell-mediated angioedema. So a lot to do, but I think a very good basis of the paper and your situation you summarized from 10 years. In Canada. So thank you very much for having you. And people, if you have any questions, or the audience who listen to this podcast, any questions to me or to Adil, do not hesitate to reach out. If you have any ideas for new topics, let us know, let me know. We would be happy to invite and talk about these future topics. Adil, I wish you a great day over there in Canada,
Thank you very much. And
and it was my pleasure.
yeah, thank you for inviting me. It was a pleasure.